Good afternoon. I'm Dena Ladd, the Executive Director for the Missouri Cures Education Foundation, whose mission is to protect and promote medical research in the state of Missouri. Thank you for joining us as we kick off our first Lunch with a Researcher series. And today our discussion is Missouri's role in COVID vaccine and treatment research. During the discussion, please feel free to put your questions in the chat box, and we hope to get to as many of your questions as possible at the end of the discussion. So now let's meet our speakers. Christine Smith is Vice President, Biotherapeutics and Pharmaceutical Sciences, Pfizer. Dr. Maddie Chiweo Davis is the Associate Program Director, Division of Infectious Diseases, Washington University School of Medicine, and she also sits on the St. Louis City Health Board. Dr. Randy Foraker, Director, Center for Population Health Informatics, Chair of Epidemiology, Strike Foresight 2, Washington University School of Medicine, and Dr. Sarah George, Associate Professor of Infectious Diseases, Allergy and Immunology at St. Louis University. Welcome, ladies. I really appreciate you taking the time to be with us today, and I know how busy you all are. So Christine, I'm gonna start with you. The Pfizer facility in St. Louis was one of the initial Pfizer sites involved in developing and manufacture of the Pfizer biointact vaccine. Explain how the St. Louis facility played a key role, and how does RNA play an important role in this vaccine?
Thank you, Dena, and thank you for the invitation to join this panel and this lunch with a researcher. Let me start by telling you a little bit about the vaccine. Pfizer BioNTech vaccine is a messenger RNA or an mRNA vaccine. And mRNA vaccines are composed of subunits that are linked together in a specific order to convey genetic instructions to make the actual protein antigen that's specific for a pathogen. In this case, the protein antigen is the spike protein on the virus that causes COVID-19. Our messenger RNA vaccine is surrounded by an oil packet composed of several lipids. That's how we formulate it. Now, once this messenger RNA of the vaccine is inside the body's cells, the cells use those instructions in the message to produce the protein antigens that are recognized by our immune system, which generate an immune response to the antigen. So in order to put the individual subunits in the messenger RNA vaccine in the right order, a template is required. And this template is a plasmid DNA molecule that's made biosynthetically and it's required at the beginning of each and every manufacturing run. And after that plasmid is manufactured, it produces the messenger RNA, and then it goes for formulation and vialing. Our Chesterfield R&D site was part of the team that developed the processes and the methods that were required to produce large volumes of the vaccine. And we are currently manufacturing that plasmid template I spoke about at the Chesterfield site. And we're also one of the sites in the global Pfizer network that provides analytical testing to support the release of the final drug product.
It's fantastic, and it's so exciting to have St. Louis play such an important role in that vaccine. So thank you, Christine. Sarah, the St. Louis University Center for Vaccine Development is one of only 10 elite NIH-funded vaccine treatment and evaluation units in the nation. You were involved in the Moderna and the Johnson & Johnson trials. Explain St. Louis University's important role in these clinical trials.
Well, thank you very much, Dena. As you say, we were one of multiple sites in the United States and worldwide where the Moderna vaccine, which is very similar to the Pfizer vaccine that Christine just discussed, where we enrolled people who consented to be in this research study, and they either received vaccine or placebo. We didn't know and they didn't know. It was a double-blind study. And then they got followed up over time. Anytime they were ill, they were asked to come in and we swabbed them to see if they had the virus. We also did swabs just when they had regular visits to come in and check on how they were doing. So we enrolled hundreds of people throughout St. Louis in those studies. I'm very grateful to each and every one of them, because without that data, we would not have the vaccines that we have now. We do have 2 of them approved in the United States. The Pfizer is one of them. And without those volunteers and without getting those studies done, we would not have those vaccines that we have right now. All those people had to contribute, and we thank them very much.
Again, that's so exciting that that took place right here in St. Louis. Thank you. Madi, we now have the new COVID variants, which I think causes all of us just a little more anxiety. What can you tell us about these variants?
So, just to be clear up front, since the start of the pandemic, SARS-CoV-2 has been mutating. This is a normal part of virology and how vaccines work. Most mutations are quite frankly useless and go undetected, but every so often you do get a series of mutations that will produce a variant that's better at infecting people and making them sick. So this is what we're seeing now. And given the swift spread of these new variants, we have experts that say the new strains contain mutations that can make it easier for the virus to bind to our cells. So this started up in December, where we saw a D614G variant that showed up in Australia and India. That was back in May. And then in December, this B117 variant in the UK, followed by the B1351 variant in South Africa, along with new variants in Los Angeles and in Ohio. So what we're seeing here is they seem to all be more transmissible than previous variants, previous variants. But we were very quick here in the US to dedicate researchers at Walter Reed with Pfizer, Moderna, and other research institutions to start looking at what impact this would have, both from a clinical standpoint, but certainly in as far as vaccine effectiveness would be concerned. So, so far, what we can agree upon with the UK variant specifically, which reached our borders first, is that yes, it does appear to be more transmissible, but there's no data to show that this in any way translate to sicker disease, but research is ongoing. And all of the research that is being done to look at how this variant fares against the vaccine products currently available are all very reassuring to date. That being said, the South African variant is the most concerning, and we recently had it confirmed on US border last week. And this one seems to be a lot more concerning by way of both transmission and what effect it can have clinically. But again, all the data thus far does lean to be reassuring in as far as the vaccine's ability to be safe and effective. And so, I want to just make a little plug here to say that we're all tired of being a part of this, global pandemic. Pandemic fatigue has surely hit me in very significant ways, and I'm sure everyone on this call. But one thing that we tend to do is to react immediately and become alarmed up front. And I think it's important to allow our medical, our research, and our public health experts to do the work they need to do and to get your information from them directly, so that we're not in this constant state of anxiety and panic that is already quite prevalent, and which I know can be very difficult.
Well, thank you, because I think you made my blood pressure go down just a little, so I appreciate this. Thank you so much. And so, Christine, what is currently understood about the Pfizer biointact vaccine and protection against the new variants?
Well, and thank you for those comments just before this around what we know about the variants. One of the reasons that Pfizer and BioNTech chose to utilize the messenger RNA platform, as Dr. George mentioned, Moderna has the same exact platform, is really due to the potential for the flexibility in the technology compared to traditional vaccine technologies. So this flexibility includes an ability to alter the RNA sequence in the vaccine to cover new strains of the virus if they were to emerge and are not well covered by the current vaccine. And the updated vaccine could be administered as a booster. So if the virus mutates in a way that an update to our vaccine would be required to continue to provide protection against a disease, we believe that the flexibility of the mRNA vaccine platform will allow us to move very quickly to adjust the vaccine as needed. And we've already shared that we are laying the groundwork to respond quickly if a variant of the COVID-19 shows evidence of escaping immunity to our vaccine. However, I have to say that, of course, the studies needed to evaluate a vaccine that encodes for an updated viral antigen have yet to be determined, and if necessary, will be done in agreement with appropriate regulatory bodies. We would still need to generate the data that would give us confidence that an updated vaccine is safe and effective. And this updated vaccine could be administered as a booster, subject, of course, to regulatory approval or authorization.
That's great, thank you. If you're just joining us, please put your questions in the chat box. We're going to try to get to as many of your questions as possible. As you can see, some of the panelists will answer the questions also in the chat box. So please put your questions there. Randy, I know you meet weekly with the leadership and staff of various departments of health in St. Louis to address their data needs, negotiate data sharing agreements, encourage appropriate sharing of data from the health systems. Tell us about the Regional Data Alliance that has been developed and why it is so important.
Yes, absolutely. And much like what Dr. Mati was saying about the increased transmission of the virus, there's also been increased transmission of data around our region, which has been very helpful in providing us what I would call situational awareness around the pandemic and what to expect next. And, you know, really the partnerships that I've seen among the health systems in the region, but also across our local public health agencies has been incredible. There's a big appetite for data sharing in our region. Washington University very quickly spun up that data sharing effort that you referred to so that we could provide a centralized repository of data that we could reason upon and provide to the St. Louis Pandemic Task Force, as well as back to the data contributors to let them know about the insights that we've derived from those data. And Dena, you also mentioned the Regional Data Alliance, which is based out of UMSL, the University of Missouri at St. Louis. And they've partnered with Doherty Business Systems to provide some data architects to the effort and to partner with specific local public health agencies to help them wrangle all of the data streams that are coming into them from the different laboratories as well as the different health systems. And so their partnership and expertise in this effort has really been phenomenal. And what I really like about their approach is that they've provided a way for us to replicate the effort across local public health agencies. They've done it in a way that's scalable and that can be reused. And I can't tell you how important that is when you're trying to do something at a large scale. You can't necessarily tailor something in a one-off way for each individual data user. And so our ability to do that really enhances our ability to make sense of all of the data that's out there in our region and state and nation, and also globally. So I think that together, all of these activities that are very complementary are critical to building a public health data infrastructure, not only in our region, but also beyond. And that's really what we felt was lacking at the beginning of the pandemic, was you know, where do we go to get this information? And so it's something that we've been able to build, again, in partnership with multiple entities across the region. And without it, I think that we would be stuck. We wouldn't be able to make the quick decisions that we're able to make.
Well, thank you, Randy. And I know that the Informatics Institute at Washington University, I mean, you all are so involved on the local level, but you're also doing a lot on the national level. So thank you for that. Dr. Mahdi, so recently I saw you in an interview, I believe it was on MSNBC. You were fabulous. And you talked about vaccine equity. And so tell us about your concerns and why community engagement is so important. And I'm also going to include this into that question. We got a question about the studies indicate high levels of vaccine hesitancy by African Americans and Hispanics. And so what are the efforts and why is community engagement so important?
Thank you so much for this question and providing a platform for this to be discussed, as I feel like it's often left behind and is much of the reason that we continue to see such significant disparities in marginalized populations and communities of colors, and specifically in Black and Brown communities. So much of my work is now centered around community engagement as part of my calling in infectious diseases and in public health in general. And, you know, I like to give a little bit of context and then talk a little bit about what I think needs to be done moving forward. So historically, there's issues here around mistrust from Black and Brown communities in government and medical and scientific communities. And this comes from a history of very well documented, abhorrent medical practices that happened in these communities. Often this is going all the way back to slavery. Since then, let me be very clear in saying up until right now, where institutional systemic racism continues in our society. And this is the very real reason for this mistrust from Black and Brown communities that is absolutely valid and understandable. That has led to historically seeing inadequate representation of people from Black and Brown communities in clinical trials in general, but specifically in vaccine development because of this, I think, in great part, history of mistrust. I will say that the vaccine trials, specifically around coronavirus, did try to address this specifically. I still believe that the representation was not as much as I would like to see in these communities, but to the credit of studies like the Moderna trial, who saw that people signing up from these communities was low, they did slow down their recruitment efforts to try to partner with communities to try to increase that number. But there's no way that you can manufacture trust overnight, or you cannot manufacture trust for the purposes of a response to this pandemic. These disparities precede COVID. We have seen disparities in this community in multiple other areas: heart disease, cancers, maternal fetal health, and many others. COVID has only shone a much needed light on this. And if we don't address this with more than superficial platitudes at this time, we will see those disparities and inequities widen. So I believe that there's two things that we're dealing with here: vaccine hesitancy because of that history of mistrust. But let's be very clear, there is a very large sector of people in Black and Brown communities that want these vaccines, but will also be left behind because of continued access issues around things like social determinants of health that prevent them from accessing information or abilities to sign up because of, you know, some people don't have working phones. They don't have the money to pay bills to be able to have functioning internet. They don't have transport to get to these places. And so these two things need to be addressed together, I believe. And I think there's a few strategies that need to start. Number one, I had no plans in my life of ever been seeing on any TV platform ever, especially not after just having a baby 2 weeks prior, and being very self-conscious about that. But I do believe in the idea of trusted messengers, people who represent the very communities that are needed here. Excellence, representation from trusted people in medicine and science and in public health to be able to lead the fore. But we can't do this in isolation. The federal government, the highest level of leadership, need to dedicate much needed funding and policy to help drive the efforts of community-based endeavors. There are community leaders and partnerships, whether it be in religious institutions and other communities, partnerships like IHN and other reputable and excellent community leaders who have earned the trust of the communities that they've served for decades now and have done this work with very little resource. But if we want to do this at the scale that will bring equity to the fore, they need to be partnered. And I'm very proud to say that the city and the county have started initiatives to do just that and to partner with them, because access will become an issue if the zip codes that, you know, Dr. Forker and her incredible team have really shed a light on where those inequities exist in our own region. If those places don't have the ability to train vaccinators, to have protocols in place to distribute, to store vaccine product, then again, the people who do want these vaccines and the people that we do educate around the mistrust and then decide they want it will not get it. So there's much more that I can say about this, but I'll stop there and happy to take any.
Thank you. Thank you so much. And Randy, besides informatics, you are so passionate about public health. And what is the St. Louis COVID Task Force doing to address some of these public health concerns?
Yes, thank you for that question. And, you know, much like Dr. Mati not being able to anticipate being on cable news, I trained as an epidemiologist, and I didn't anticipate being put in the position to analyze data during a pandemic. Specifically, my area of expertise is chronic disease. So imagine my surprise when all of a sudden I have to read up and understand infectious disease as well. So, you know, I think that from the public health standpoint, we have seen huge health inequities in our region. And the pandemic, I think, has really opened our eyes to that chasm of inequality that exists. And in particular, during the beginning of the pandemic, we saw underserved populations really hit the hardest and bear the burden of the pandemic. And now, you know, as the panel has already spoken to, the need for vaccines to be able to reach these underserved populations as well. So we see that the infrastructure isn't necessarily in place for us to deliver care to these communities in a care continuity sort of a way. And same thing with prevention like vaccines. So even putting aside the concerns around mistrust, just having the infrastructure to be able to meet underserved populations literally where they are in those locations to deliver the appropriate care, but also the vaccines. And I think that, you know, the pandemic task force in our region, as well as all efforts that are being undertaken to analyze the data that we have at our disposal, everyone has a keen eye on health equity. And in particular, we want to make sure that we're able to highlight health inequities where they exist, but also to engage the appropriate people to do something about it, which is why I think it's so critical for the health systems to be working together, like I addressed earlier, as well as all of the local public health agencies who have connections with these communities and can help us to better deliver interventions in these communities and communicate the benefits of the vaccine, for example, to underserved communities in our region. And I just want to highlight another group that I'm a part of called the Comparative Modeling Network. And it brings together health system representatives, academics, and local public health agencies. And they've all taken an interest in different aspects of the pandemic, from preventative behaviors like wearing a mask to vaccination and immunity to cases and how the virus spreads in schools. And so all of these different subgroups, a theme that runs across all of those subgroups of data analytic experts is health equity. And so they want to make sure that they're communicating the results about where disparities are, engaging the appropriate people to do something about it. But also, if we're developing algorithms to try and predict the outcome of the pandemic, are those algorithms inherently biased because we may not have the data from underserved communities reflected in those algorithms? So the answers that we get from those algorithms may not actually apply to the underserved populations that we definitely need to double down and help through this pandemic.
I'm going to kind of stick with that subject because we're getting a lot of questions, and Dr. Mahdi and Randy and everyone else, specifically, you know, what is being done to get the vaccine to the underserved community, and can people help in some way? And Dr. Mahdi, I know you just joined the St. Louis City Health Board, and I'm assuming that's one reason you did that, because you care so passionately about this subject.
So I can start a little bit here and provide a little bit of context. So we have all been, you know, anyone who's seen me on the Board of Health meetings know that I'm like a broken record, and they know as soon as they give me an update, I'm going to lead with what are we doing for equitable access. And so they just need to get used to the fact that that's the broken record that will continue. So a little bit about what I've been told is we need to understand that we're still playing catch up with what I believe has been a woefully inadequate vaccine rollout since December. So what's happened is that states have been given limited vaccine product and then have had to piecemeal vaccines to different distributions across Missouri. I won't get into the politics of that because I don't think it's a productive conversation, but I will say that it's made it very challenging so I can give an example where, you know, 3 weeks ago, the county had access to a certain number of vaccines, very limited in supply, and I believe had an excellent plan to get that vaccine out to the priority groups at the time. The city, however, were sent zero product. And that can be very confusing for people who literally live within 10 minutes of each other as to why some can get vaccine and others cannot, right? But that's coming from, again, like I'm saying, an insufficient vaccine product. So what the city has been doing has been preparing for when they do get vaccine product, which happened last week. Again, very limited supply. And they do have to follow the guidelines of what the state has given as priority groups, such as nursing homes, healthcare workers that were not included in the first wave and didn't have access to organizations that they could get that vaccine product from. And then people who are in the elderly and higher risk. Again, I pushed and continue to push for what does that mean for Black and Brown communities. I think people are very nervous to say Black and Brown and are more comfortable dealing with the data around some of the other at-risk groups. And what I've been told by Dr. Eckel, the Director of Health for the city, is that in the meantime, there has been already coordinated efforts to partner with community groups, like I mentioned earlier, to get ready certain access sites for vaccine distribution and to deal with some of the things that need to be put in place to support that rollout when the product becomes available. They also have set up a hotline that you can access through the city, and I'm happy to amplify through my platforms too, that people can call. So we know that some people may not have access to working phones all the time. That's where the community groups being on the ground and seeing these people in their different areas of expertise, whether it be healthcare and other reasons they access these places, can then take their information and send it along to the city. People who do call the hotline can do so with questions to sign up, but also specifically, Dr. Eccles is calling for people to give the interns that are staffing these hotlines information as to barriers to care. And then they can be provided with information as to how to overcome those barriers. And so those plans are already being put in place as how to partner with these community groups to get vaccines out. There's even resources being directed towards mobile vans for people who are not able, you know, the disabled or other people who have other social determinants of health or barriers to getting to some of the sites for mobile units to come to their homes. I'll be honest, I continue to have concerns, and that's why I will continue to try to lead in my capacity as a board member around things like we've heard that the federal guard is going to be utilized in this. You know, there's obvious issues with mistrust already in government and science, you know, communities, let alone those in uniform. So I do think that needs to be addressed. And again, centering the partnership with community organizations and multiple other barriers. And I see a lot of questions as to how people can help. Number one, continue to advocate in your certain spheres, continue to ask for a lens on equity, whether you work in a hospital, in a community organization, and what that is. And ask, what data are we using to support equity? What are the specific things that are being done to support this? There's still a lot of work that can be done, but I'll allow other panelists to give their thoughts on this topic as well.
This is Sarah George. If I could just say here, we definitely need to improve service to underserved communities, whereas Dr. Davis says the issue is often transportation and availability of phones. And that means things like the open air clinic or open vaccine clinic that St. Louis City had just recently. I realize that that has been criticized somewhat in the media for being imperfect, or everything's going to be imperfect at this time. But still, that did good service. Vaccinating, I think it was maybe 1,800 people. Correct me if I'm wrong, Dr. Davis, on that. And you know, that's where you have to start. You have to bring the vaccine to them, because often they cannot get to the vaccine because of transportation issues and information and so on. And again, you know, we talked earlier about the vaccine variants, you know, even that South African variant, which is causing some concern right now, the data are that the existing approved vaccines or similar ones are still about 60% effective against it. Now that in HIV negative people, now that's not the 95% we were seeing with the existing types, but still 60% or so is still doing very, very well, much better than 0%. So thank you very much.
Yeah, I will say that the questions in the chat box, and some people have my cell phone number. I'm getting a lot of questions on my phone, but it's all around the vaccine. I mean, that is what we all care about right now is, you know, how to obtain the vaccine, how to get it to people who need it. And so Christine, can you tell us a little bit about the current production and distribution of the vaccine to meet the demand?
Sure, thanks. Well, what I can definitely tell you is that we are working around the clock to manufacture and really release millions of doses each week. And the volume continues to grow as we ramp up our manufacturing. I like to say that the sun never sets across our manufacturing network. And because of this ramp up, you know, we have announced that we are confident in our ability to deliver 200 million doses to the US government by the end of July this year. We're operating under an emergency use authorization, and we will continue to dispatch orders to the locations that are specified by the US government. And you know, because of the need to vaccinate many, many more people, we continue to look at innovative approaches and plans to increase the number of doses that we're going to be able to produce by the end of 2021. We now believe that we have potential to deliver approximately 2 billion in total by the end of 2021.
So, Sarah, I know that there are ongoing COVID treatment trials at St. Louis University, and I actually got another question here about also the therapies for COVID, and I know you were instrumental in some of those trials. Could you speak to that?
Well, thank you. So again, a lot of this still for months and months down the road is going to be prevention, social distancing, masking, hand washing. We need to keep doing it. Get the vaccine as soon as you are eligible to do so. But we have lots and lots of people in the hospital. And as everyone knows, we've now had more than 400,000 deaths in this country. We've made a lot of progress on how to treat this disease. It was definitely a learning curve. The death rate was much higher early on in the pandemic back in March, April, and so on through May. But we do now have a number of licensed therapeutics. There's an antibody treatment, which can be used in the outpatient setting. People who are not sick enough in the hospital. There are some logistical issues with that because you have to get it infused. On the inpatient setting, we have a emergency approved authorization of an antiviral remdesivir, and St. Louis University was one of the areas where that was, one of the sites where that was tested. It's not perfect, but again, everything that reduces the burden of this disease helps. We also have other drugs that have been shown to be effective, including steroids, and there are other ones being tested right now. There's an anti-inflammatory called baricitinib, which was originally developed against arthritis of all things, but has been shown to be effective in people who are sick enough to need oxygen and be in a hospital with this disease. And some of it, again, is just learning over time. The lung doctors who often deal with those people with respiratory failure have learned how to manage this disease better. So the death rates are not what they were back in March and April and so on. They are still substantial. I don't recall the numbers right now. I think it's still several thousand Americans dying every day of this disease, or about 1 every 6 minutes is what I believe I read yesterday. But progress is being made and more is coming. Thank you.
So some of the other questions are about the value of using a vaccine like Janssen, a vaccine that has lower reported success rate. Can anyone address that question?
I think the Janssen success rate was about 90%, if I remember correctly, whereas the AstraZeneca one made by Oxford, which is not approved in this country, was about 70%. Neither of those are yet approved in this country. And the different vaccines are made in kind of different ways, and some of them are going to vary in their protective effect. Right now, we have the 2 approved vaccines in this country, Moderna and Pfizer. Anybody else?
No. Okay. And I know there's been some concerns. You know, we were talking earlier about education of the vaccine and getting people to get vaccinated. And there was something that I saw on one of the news channels last night about young adults getting vaccinated and the chance of possibly affecting their fertility. So how do you address those issues? And have you heard of anything similar to young adults getting vaccinated and any effects that could happen to them?
Well, so these vaccines do have some side effects. Fertility compromise is not one of them. That sounds like another internet rumor to me. But yes, you know, like with all shots, you can certainly get a sore arm afterward. And again, this one, it can give you a little bit more of a side effect. Some people do get wiped out for a day or so. And by that, I mean, you know, fever, fatigue, achy, may have to go home, go to bed for a day or so. Most people don't have reactions that severe, but some people do. You're actually more likely to have more significant reactions if you're younger, by the way. So, you know, age and beauty go together, I guess, or maybe less reactive to the vaccine. But again, the 2 existing approved vaccines, Pfizer and Moderna, 95% effective in the trials. You do need both shots, but they do work. And they do work even maybe a little less effectively against the South African variant. So, you know, you can expect to have some side effects. Just please try and bear with it. These vaccines do work, and please be cautious listening to internet rumors about things like, oh, it affects your fertility. There's just no evidence for that. Thank you very much. Anyone else?
I'll just add to what Dr. George was saying, because she's absolutely right. So first of all, you know, a little bit about what I like to counsel patients on when I talk about the vaccine. The first is that these clinical trials showed such high efficacy. And I think it's always good to provide context, right? We do a flu vaccine every year that is usually within the 50 to 70% if effective rate, and look at the significant impact it's had on both disease and death. And so to be, you know, we're really sort of, you know, we're really sort of nitpicking when we start talking about the kind of effectiveness that we're talking at across studies. This this is an incredibly effective vaccine, even when there's a little bit of variation. And as far as safety goes, Dr. George is absolutely correct in the safety profile that's been given. But when I talk to people, what I like to remind them is this. When you're talking about whether or not to get a vaccine, you're not discussing, the choice between the risks and benefits of a vaccine versus nothing. You're deciding between the risks and benefits of this vaccine versus the risks and benefits of getting COVID, which include death. And with the kind of safety that we've seen and the very mild side effects, I've had multiple colleagues who only experienced, myself included, that arm soreness. And of those lower percentage that more commonly after the second shot got the headache or the fever or the muscle aches that were reported in the clinical trials, those lasted only a day to two. And most people were fine thereafter, and would get it without question, given the opportunity again. There's a lot of misinformation out there. My approach is not to lead with ridicule, especially because a lot of that comes from this fear of what happened in the past, whether it be from Tuskegee or other experiences, or just from a lack of understanding. Not everyone has access to the same information that I have. So I lead with doing exactly what we're all doing here, reaffirming what the correct information is and going to trusted sources like the CDC's website, like your doctors, rather than the school of Facebook, Twitter, and Instagram, which cannot be the direct source of information.
Yes, thank you. So we have a question here about the mask recommendation. They've recommended wearing double masks, or what is the best type of mask for the average individual?
If I understood the question correctly, we're all still recommended to wear masks. They're getting the vaccination, and that goes for healthcare workers like me, does not at this time mean you should not continue all the protection you should do previously: masking, social distancing, hand washing, etc. As the CDC and the NIH and Dr. Fauci are saying, we've got to continue this for probably another 6 months or so, until we are hopefully going to be somewhat out of the woods. Did I answer the question?
Yeah, and the double masking. I know that's been a big topic recently.
I mean, the standard mask, I've got one here, is perfectly good. And the cloth masks that a lot of people are wearing, again, they usually recommend 2 or 3 layers of cloth. A single layer of cloth is not as good as 2 or 3 layers. I do believe there's data for that.
Mm-hmm. Mm-hmm. We also have a question about, if you've had COVID, then when should you get the vaccine? Is there a certain period of time you should wait?
So the CDC has said that there's a range, you can get the vaccine as early as after 2 weeks from the time of quarantine, but you can wait for as long as 90 days from the time that you were diagnosed. I think that can be confusing for people. It doesn't mean that they're saying you should wait up to the 90 days, but they're saying that for folks who want to, they can. My belief is that if you're outside of the window of, and I'm sorry, let me be clear about what they say about the shorter time, and that also you must be outside of the symptomatic window. For folks who are outside of that window, though, I believe that you should be in direct contact with your primary care provider and talking about the best time, because not each case is exactly the same and what you're dealing with. But certainly, no one should feel that just because they've had COVID that do not need the vaccine, because that's absolutely not true, and we have no data to support that at this time. Having said that, even people who have had the vaccine need to be following masking and other public health prevention strategies, such as social distancing, hand washing, and not partaking in large gatherings, because the data that we have so far, and let's be clear, data is still being collected in all of these clinical trials so that we have more long-term data, did not follow what happens with asymptomatic folks, right? So we don't know for sure what happens around people who are asymptomatic and have the vaccine. So until we reach herd immunity, it's imperative that folks continue to mask up.
Yeah, Definitely. There was a question in the chat box, and Randy, thank you. You answered it, but I'd like to discuss it a little in case people are not looking at the chat box. It talks about the Data Alliance, tracking vaccinations by location, age, occupation. Is that happening?
Yes. So each health system, I'll give that as an example, is tracking the allocation of the vaccines in their own electronic health records. So the next step is to work with entities like the Regional Data Alliance to bring those data assets together so that we can get a better picture from across the region in terms of how we're doing with vaccine allocation according to age groups and races. We won't have information on occupation specifically, but we will on location at the level of the zip code. So we'll be able to see how evenly the vaccine is being distributed across these groups. And, you know, it's important to keep in mind that we're following allocation recommendations according to the patient's age and any comorbid conditions that they may have and so forth. So the distribution of the vaccine might look inequitable from an age standpoint for a while, just because the younger people that are getting vaccinated currently qualify for other reasons, like being healthcare workers, for example.
Yeah. That's great. You know, the great thing about doing virtual events like today, we were able to have people all around the state join us to hear all of you experts and even people outside of Missouri. And so I am curious, if you live in a small town in Missouri, or if you're over in Kansas City or Columbia, we'd love to have you put something in the chat box and let us know how the vaccine rollout is happening in your community. Because I definitely think they had something on the news yesterday about Cape Girardeau and how they are really getting out there vaccinating their community compared to like St. Louis. And so why do you think the communities differ from small town, big towns? And is in our smaller towns challenged with the fact that the vaccine has to be stored at a certain temperature?
Well, the vaccine does need to be, the two existing approved vaccines do need to be stored at low temperatures, but I mean, we knew for months that this was coming. So we were able to prepare for that as best we could. There certainly are ultra low freezers available. And the vaccines do have a certain window of time that you can use them after they've been thawed. You probably saw in the news, maybe it was last week, that I think it was maybe in Oregon or Seattle, they had thawed a bunch of vaccine and then there was a snowstorm and they were just frantically distributing it to something like 16 or 1,800 people to make sure none of it went to waste. So there is a time window after the vaccine gets thawed where it can be used. And that may evolve over time as we try vaccine stability testing at lower temperatures. I'm not sure exactly where that is, but it may evolve. Thank you.
And I'd like to ask this final question to all of you. As we look at 2021, can each of you talk about the priority of your organization when dealing with this pandemic? And Christine, I'll let you go first.
Thank you. I'll just comment that at Pfizer, we are looking at other ways to formulate these vaccines so that we could allow additional flexibility in that cold chain storage. But back to getting to normal, wow, I really look forward to it. I look forward to, you know, making sure all the scientists are back at my site in St. Louis and we can interact, because scientists really love to talk to each other and not just over a computer screen. Pfizer, you know, as a large pharmaceutical company, has a portfolio of medicines and vaccines that go across many different research and therapeutic areas. And there's a lot of work to do here. There's a lot of unmet medical need. We work on novel therapies from oncology to immunology and inflammation, internal medicine, and rare disease, where we actually have several ongoing gene therapy clinical trials. And we just look forward to focusing our efforts across all those unmet medical needs and really trying to create breakthroughs that change patients' lives, because that's our purpose.
That's great. Randy?
Yes, from our perspective, we've done a lot of talking about how we're going to get back to normal and how we care for each other, not when the pandemic ends, but before it ends, because all of us have been operating at such a high level and effort percentage since this started that we're worried about the toll that it's taking on everyone. I believe we've already referred to, you know, the exhaustion that the pandemic has instilled in all of us, you know, here on this panel today. And so I think that it's really important to be thoughtful about all that our employees are dealing with at home/work, right? Because now there's not very much of a distinction between the two. And when we get back to normal, we're going to have to readjust to having home perhaps separate from work, and then what that readjustment looks like and what our expectation looks like as well for the people in our care, right? Our employees.
Dr. Mahdi?
I want to start with addressing two questions that I saw in the chat briefly that can be smushed together. It's around vaccines and immunocompromised as well as allergies. I want to be clear in saying the only contraindication to taking the vaccine that the CDC has stated is in folks who have allergic response to vaccines previously, and that other folks who have concerns around allergies or around their immunocompromised states should be speaking with their healthcare providers. The biology does not suggest, while the clinical trials were not designed to look at individual immunosuppressed groups of people in a way that can give conclusive recommendations, the biology doesn't support that those individuals should be excluded. However, individual considerations around the timing of certain certain drugs and around the care of immunocompromised folks do need to be taken into account. And in most cases, that still means you can get the vaccine, but just have to be thoughtful about when to take the vaccine, to get the vaccine. So I just say, talk to your healthcare provider, but do not assume that you would be exempt from being able to get the vaccine. In talking about what I am seeing in my institutions, you know, my intersectionality, I'll speak a little bit to, number one, I do have, most of my work is at the John Cochrane VA, and they have done a phenomenal job of distributing vaccine and are currently providing vaccine to veterans in the general population. That rollout has been very well thought out. There's been a great mechanism to contact veterans. I, of course, am trying to lend a hand around populations that are hard to access, both rural populations that are very far out and have difficulty with access in general, and then local marginalized populations. At WashU, I think WashU is going to be one of the sites that's going to be delivering vaccine product and has really centered data-driven approaches to what that should look like. And that's, again, much thanks to the work of folks like Dr. Foraker, who's with us today. And really, I mean, she's so humble, but has been a champion around how the procurement of data and how it can be utilized to inform policy. And then in the city, I think I spoke to the fact that there is already plans underway about how to really do an equitable vaccine rollout. So I think those are the priorities in the 3 jurisdictions that I'm a part of.
Thank you. And Sarah?
Well, thank you. It's a great pleasure to be part of this panel. There's a lot of work yet to be done. We will be doing ongoing vaccine trials. We've got some more with different vaccines coming up. We're still following the people in the initial trials. Those people will get followed for 2 years. Because one of the questions we don't have an answer to now is how long you have immunity to after the vaccination. We're still doing ongoing treatment studies, and we're still working on trying to reach out more to underserved and marginalized populations. One of the things we found is that doing telehealth from a neighborhood church is actually pretty effective. Everybody knows, well, not everybody, a lot of people know where their church is. It's not far for them to go. And if you can set up a telehealth there or a vaccine clinic there, that's a good place to go. You're bringing healthcare and the vaccine to the people. Thank you.
Mm-hmm. Well, I want to be respectful of your time. I feel so fortunate that the four of you rock star women could take an hour out of your day to talk about this really important subject, and how fortunate we are to have all of you here in our state, in our community. So thank you so much. And I would ask everyone to go to our website, MissouriCures.org. We have a list of our upcoming events, and on March 3rd, our next lunch with a researcher will be focused on diabetes. So again, thank you everyone for joining us today.
Thank you.